given the fact that transplant is increasingly the central curative option for fit adults with AML. And increasingly, the question is who shouldn't have a transplant rather than who should have a transplant. And that's important, I think, particularly in older patients, maybe over 55. The dynamic risk assessment that was articulated by the ELN about 10 years ago, which includes a prediction of relapse risk if patients receive chemotherapy alone, allowing you to predict the reduction in relapse risk, given the fact that transplant reduces the risk of relapse by about 65%, coupled with a predicted transplant-related mortality using a well-matched donor, is now kind of widely adopted. And whether you're pro-transplant or not, I think there's a kind of gathering consensus that if you're a fit adult and you have a well-matched donor, if your predicted risk of relapse is more than, say, 40%, then you're very likely to benefit from transplant. Now, of course, these are complicated decisions. We have to be thoughtful that, particularly as we take transplant into an older patient population, not only that the data shows that providing patients are fit, actually age doesn't matter too much, but often older patients have complex social circumstances. They may have care dependencies. And so deciding as to whether to proceed to transplant is a fairly straightforward decision, I think, nowadays in terms of using this dynamic assessment. But there are also considerable other factors that we need to bring into the equation before making a decision whether to proceed to transplant. But suffice it to say that I think the NCCN recommendations have got it right, that if you've got a patient with non-favorable risk AML, you should start a sibling and unrelated donor search whilst the patient is undergoing induction chemotherapy. And transplant, therefore, is standard of care now. I think you've got favorable risk AML, but you can't complete consolidation chemotherapy. Or if you've got intermediate risk or adverse risk AML. CR2 patients has clear evidence of benefit with transplant. I think one area for discussion is which patients with primary refractory AML derive benefit from transplant. There is consistent published data now that about 25% of patients with primary refractory AML are fulfilling the ELN 2022 criteria. In other words, persistent disease after 2 courses of induction chemotherapy, including 1 course of high-dose ARSC. 25% of patients with otherwise unsalvageable disease are long-term survivors. The challenge, of course, is to identify which are those patients who will benefit. Next slide, please. So we've discussed this, and I'll move through this quite quickly, actually, but it's a simple risk assessment on the basis of genetics and MRD response where that applies, and predicted risk of transplant-related mortality on the basis of donor availability and also fitness, critically fitness. So our policy is we're transplanting patients up to the age of 75, providing they're fit and well before diagnosis of AML. Next slide, please. And this is such an important area that we wanted to devote just one slide to it. We recently published in Blood data from the CIBMTR showing really good outcomes in adults over 60 and indeed adults over 70, providing they're fit, but also MD Anderson data showing that until recently, only a small number of such patients proceed to transplant. But actually, if you can get a good link between the leukemia program and the transplant program, you can drive the number of patients who are fit over 60 with AML who actually go to transplant up to 45 or 50%. And there's accumulating data of increased transplant rates in this older population. So the approach that is taken, generally, I think now, is identifying relapse risk, then sitting down with the patient and really being quite meticulous about fitness assessment. I think it is important to recognize that in people over 60, if they've got significant comorbidities, they're unlikely to tolerate transplant well, and they're particularly unlikely to tolerate steroids applied for graft versus host disease. And then in fit patients with a high risk, off you go to transplant. And this applies up to 75. Next slide. So I think one area of unmet need is refining our definition of fitness. We currently use the HCTCI, but of course, everybody's aware of patients who actually have a bad HCTCI score, who happen to go to transplant and do quite well, or conversely, patients who have a HCTCI score of 0 and fall apart after transplant. My sense is that it's not the first 100 days that are the challenge. In fact, consistently across prospective studies in this older population, the TRM at day 100 is about 3%. It is beyond that, particularly in patients who get GVHD and have received steroids, where the toxicity rises to 15 to 18%. And so I think there's a big opportunity here, actually, for us to apply prognostic biomarkers to predict intolerance to steroids. And this seems to me an area of significant unmet need. And then I think it's also important just to flip it around the other way and to recognize that for patients who aren't fit for transplant or who don't want to transplant, if they're FLT3 mutated, there's now quite impressive evidence of benefit from maintenance quizartinib. We also have evidence of CC486 in patients who don't proceed to transplant after intensive chemotherapy. So there are increasingly treatment options in patients who we don't think we can take to transplant. Next slide. I think we're likely to refine our patient selection algorithm for transplant in the next decade. It's very possible that we have improved salvage strategies for people who relapse having achieved CR1. We can think of the AML data using gilteritinib salvage. We can think of the data from a number of groups now, but I think pioneered by Courtney DiNardo, showing the addition of VEN to intensive chemotherapy in their setting, FLAG-IDA, gave high CR2 rates in patients relapsing with intermittent or adverse risk disease, but not TP53 mutated. So it's perfectly plausible, I think, that there are going to be patients who are in CR1 who we have more confidence that should they relapse, we can get them safely back into CR2 and then proceed to transplant. But randomized data of the benefit of a VEN-based salvage regimen as opposed to standard intensive chemotherapy is still lacking. And I think many of us would still be deferring towards a CR1 allograft. Second area of contention, of course, is receding a bit now. There was a small underpowered study from the German transplant group suggesting that in patients who have active relapse, they may do just as well if they go straight to transplant rather than receiving salvage chemotherapy and then go to transplant in CL2. I think it's a hypothesis generating study. The study was underpowered. Most of the patients who were studied actually were in CR1, they just hadn't achieved CR after first course of induction. And the challenge with the data that was presented was not only small numbers, but also we didn't have any idea about molecular subgroups, whether it was TP53, this was equally appropriate. But nonetheless, I think it is an interesting prospective question. And I think that further studies of which patients with relapsed AML may do well with without standard salvage chemotherapy, but just going into, say, a sequential allograft. It's perfectly plausible given the fact that sequential allograft, which is what they used in that study, has a week's chemo and then a break and then a standard RIG. Perfectly plausible that patients with very chemosensitive disease, that's good enough because that first week of the sequential regimen may get them back into CR and then off you go. But I think we do need data. Now, finally, I think this whole question about if you have a patient who is fit, who is in a CR1, who has evidence of immunophenotypic or molecular MRD, who cannot tolerate a MAC, and that's about 2/3 of our patients. They're of an age where they really can't tolerate a MAC. Should you go straight to transplant, or should you give them intensive chemotherapy, hopefully reduce the MRD, and then go to transplant? And this is an area I think that is divided opinion. And part of the reason it's divided opinion is we haven't got compelling data at all to suggest that there is any benefit for patients with MRD positive CR1, that they benefit from a course of further intensive chemotherapy before going to transplant. So to say that it's standard of care to give chemo and then go to transplant, I don't think it's justified. I'm not aware of robust data. And I think those of us who believe these patients should route through to transplant are also persuaded by prospective studies. We've done a couple in the UK showing that if you are in CR1, you're MRD positive, and you go to a RIG, your overall survival at 2 years is 40 or 45%. So it's not like it's a disaster. But I'm aware also there are other colleagues who have strong opinions that these people should have further intensive chemo. And clearly this is an area for prospective studies. And then finally, where are we with myeloablative conditioning regimens? Well, I personally, I think if the patient's fit enough, in other words, 50 and younger and no comorbidities, and they're MRD positive, you should certainly try and give a myeloablative. But otherwise, I don't think there's persuasive evidence of a safety of such regimens in older patients. So next slide, please. So those were, Natasha, kind of 3 or 4 areas of contention. And I'm aware that not everybody will agree with the opinions I've articulated. And the reason I articulated them was partly just to stimulate a discussion. But perhaps we might have 2 or 3 minutes just now to open up the discussion. And I'm going to suggest that Josh Zeidner just kicks off with any thoughts about any of these 4 areas of contention. Josh, what's your feeling?
Well, I think you hit the nail on the head that, many of these questions are going to be controversial. And, I think that there's not a standard. So it's going to be very challenging for us to provide like uniform consensus recommendations or guidelines. But I think that these are such important clinically relevant topics that, these seem like, the ideal sort of questions that we should address and foster through like the AML Hub with, existing data and foster conversation. I'm happy to provide, my input on some of these, but I think, I'm also not, a transplanter. So, we're kind of unfortunately reliant on our transplant colleagues at my institution to make many of these decisions about who does or does not move forward with transplant. And we have these active discussions all the time, actually, in our, weekly consensus meetings. But, I don't at my institution decide who does or does not go to transplant, despite my push and prioritization.
Maybe before I turn to Jessica, Josh, you're underlining the point that we should think about ourselves more as a sort of holistic treatment modality, induction, chemo, and transplant, and perhaps have more dialogue between our programs. I couldn't agree with you more. I wanted to ask Jessica. Jessica, you may have your own comments, but can I just ask you a question first? Is in patients with FLT3 mutated AML in CR1, are there any patient populations who are fit and have a donor where you're confidently recommending they shouldn't proceed to transplant?
Thanks, Charlie. I will get to that. And I agree with your comments and what Josh noted. I want to answer that, but I want to make a couple of comments about some of the questions that you rose or provided for us. Number one, should relapsed AML patients receive salvage therapy or proceed straight to transplant? And those who are MRD positive, should they go to transplant or should we try something else? These are questions that we've been grappling with, and it certainly won't answer these questions, but maybe one step is we could try to pool our data of the patients across multiple institutions, across multiple countries and continents. If we could pool our data and see who the patients are who are going straight to transplant with MRD positive or straight to transplant with relapsed disease, because I think that's something that the hub really, we have access to a lot of folks, and we all, have colleagues throughout the field. So that would be my one recommendation if that's something we want to kind of think through as a team. Regarding those who are FLT3, history of FLT3 ITD mutated AML, likely those NPM1 positive patients who are fit for stem cell transplant and MRD negative. Today, those are patients that we're still recommending stem cell transplant because that appears not to be, it's not detrimental. I mean, certainly for individual patients, it can be very detrimental, but I'm waiting for more data. So that also would be nice to get some real world evidence from experienced transplant leukemia centers to review as well.
Super.
But I'm interested in everyone else's thoughts.
Thanks, Jessica. I'll probably come back to you, but Jeff and then Courtney.
I guess one comment, I have two comments. One would be that it might be useful to add to an important discussion point on the role of transplant in this cohort of patients who are MRD negative in CR1. I think that's an increasingly controversial area because of our ability to achieve high sensitivity MRD testing and the knowledge that maybe not all mutations behave equally when they're MRD negative. So having the question come to the front of the line there with regard to MRD negative and the knowledge that you do have a minority of patients who achieve relapse-free survival without transplant. I think addressing the MRD negative population in some comprehensive way would make sense. And to that point, my second comment would be, I think we're entering a phase where we need to probably leverage AI better when it comes to decision making in these groups. There's just so many data points, and we traditionally look at things in sort of a binary fashion. If you have, if you have ELN defined or NCCN defined risk, you have this outcome. But within those groups, there are so many different variables that affect the outcomes that it's almost impossible to really understand how any individual patient will behave without, delving more into it in a multifaceted fashion through AI. And I think AI-based outcomes are going to be really critical in kind of understanding the landscape of treating these patients that are being considered for transplant, because the outcomes are likely.
That's a great point. That's a great point.
I really appreciate the discussion. Thank you.
Getting some prospective data on which patients with primary refractory AML actually do well, particularly using a rather more refined data and analytical approach, is a great idea. You may want to subsequently comment, because I think there's a German study which is looking at the MRD negative population benefit of transplant. But Courtney first.
Yeah, thanks. I was going to say many of the same things, so I won't belabor that. But I think the table that you showed in one of the previous slides of kind of newly diagnosed and salvage and MRD positive and MRD negative and rates of relapse and expected survival with transplant, expected relapse with transplant. I don't remember it exactly, but that was a really, I think, useful table. And I haven't seen it presented quite so usefully in a lot of other situations. So I think building off of that, and for the AML Hub, using this and kind of showcasing this table, and then kind of as we get better with these different subsets that we've talked about, are there different groups within this that we can build out even better and have better assessments of relapse risk for them, I think is a really, I mean, we're so data driven and we have so many numbers, but actually the true risk of relapse in a patient with a certain type of intermediate risk disease, or the true risk of kind of survival and relapse post-transplant with a specific genomic subset, I think is not something that we all know as well as we could with, better analysis of all of our data.
Yeah, I mean, it's a great point. I think building on Jeff's and also getting prospective data, right, Courtney? I mean, we could do that banding together. Perhaps Roland has the last comment. Roland.
No, I mean, I think Courtney just sort of segued into what I was trying to say. I mean, I really like your discussion slide, but the one thing that is sort of missing on it, and it's sort of whole basis of the transplant decision making, is like, what is the risk of relapse or transplant related mortality? And we might do okay on a cohort level, but for individual patients, we really are terribly not good. And that's true for what Courtney said with the relapse prediction, but it's even worse for non-relapse mortality prediction, right? I mean, we use HCTCI score, but their predictive ability is, I mean, close to a flip of a coin, even in the cohort where it was developed. So they're not particularly good tools, yet we're making all transplant decisions basically on our probably somewhat delusional thinking that we can estimate these risks somewhat accurately. So it's sort of an interesting idea that we're making transplant decisions on two variables that we're very, very bad in predicting, and building everything from it.
Yeah, I agree. I think also, I mean, the contribution of Courtney to this field has been really important in terms of if we could move the dial on reliably salvaging certain populations of patients, that really does change your transplant decision making, and we need some randomized studies in this space. But I'll close it on that. Thank everybody for their contributions.